Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is Introduction to Opportunistic Infections and the Opportunistic Infection Central Nervous System. The speaker is Dr. Dolanchampa Modak ma'am. Dr. Dolanchampa Modak ma'am is the Deputy Director with COE STM. She is the Assistant Professor of Tropical Medicine with School of Tropical Medicine, Kolkata. She is also a Master Trainer for NACO and a faculty of PG Diploma in HIV Medicine course for IGNO. She has several publications in national and international journals. We welcome you, ma'am, for today's session and request you to start the session. Ma'am, your mic is on mute.
Okay.
Yes, ma'am, you're audible.
Sita,
Yes,
can I?
ma'am.
Okay.
Yes,
Yeah. Good morning, everybody. So today's session is about the introduction to opportunistic infections, the part 1, and the second part we will discuss the central nervous system infection, especially among the HIV infected patients. So slide share, Ismail, they will or?
ma'am, the slides are visible. It's shared from your end, ma'am.
Okay. So this is a very important session, and regarding the opportunistic infections, we'll discuss the introduction, central nervous system, respiratory, genitourinary, gastrointestinal system, and the skin and mucous membrane involvement. So the common symptoms and signs of opportunistic infection among the HIV infected patients depends upon the system involvement. Like in central nervous systems, neurological systems, common symptoms of meningitis. Cryptococcal and tubercular meningitis are the common meningitis in the HIV infected patients, and the patients usually comes with headache, neck rigidity, altered consciousness, and so on. And the toxoplasmosis, they usually present with the focal neurological symptoms. Cytomegalovirus infections usually have the local symptoms like the eye involvement. There may be blindness, progressive multifocal leukoencephalopathy. We'll discuss it elaborately later. And the hand, that is the HIV associated neurocognitive disorder, HIV-associated vacuolar myelopathy, primary CNS lymphoma, HIV-associated neuropathies, and last but not the least is neurosyphilis. These are the very important CNS manifestations and opportunistic infections we commonly seen in our day-to-day life among the HIV-infected patients. Regarding opportunistic infection, so what is this? Opportunistic infection, that is an infection caused by a microbial agent in a person who is HIV infected, that is with a compromised immune system. And AIDS is defined as the occurrence of the life-threatening opportunistic infections, malignancies, neurological disease, and other specific illness in the very advanced stage of the HIV illness, that is when the CD4 comes down less than 200 cells per cubic microliter. So the opportunistic infections are the major cause of morbidity and mortality among this group of infection, and it is very important for the early diagnosis of the opportunistic infection so that we can save the life of the patient. And for that reason, screening of the opportunistic infections are very important before starting ART, particularly tuberculosis and cryptococcal. Many few important opportunistic infections should be ruled out, and judicious use of the chemotherapy and immune prophylaxis are there in the guideline to prevent the various opportunistic infections which favorably impact have survival benefit among the PLHIV. And in a systemic review, here, okay. একটা ক্লাসে আছি, পরে 1 ঘন্টা পরে কথা বলছি। In a systemic review, it shows that ART led to the greatest reductions in incidence of all opportunistic infection during the first 12 months of ART, except for TB, and it was the largest for oral candidiasis and PCP or PJP and toxoplasmosis. So the Incidence of opportunistic infection. Incidence depends upon the endemic prevalence of the causative agent, and that likely that tuberculosis is endemic. We are endemic in the tuberculosis in India. So most common opportunistic infection among the HIV infected patient is tuberculosis, and the level of immunosuppression, advanced HIV illness, where the chance of life-threatening opportunistic infections are much more. So it depends upon these two factors. And different CD4 levels have different prevalence of opportunistic infection, like the Mycobacterium tuberculosis infection, particularly pulmonary tuberculosis, is seen around the CD4 level of the 500, and oral candidiasis, molluscum contagiosum, dermatitis, folliculitis in between 300 to 400. And when there is advanced HIV illness, that is CD4 less than 200 cells per cubic millimeter, then the HIV as will be associated with pneumocystitis, girovecin pneumonia. There may be cryptococcal meningitis, toxoplasmosis, NHL, and so many like CMV retinitis, CMV colitis, PMLE, microsporidiosis, and primary CNS lymphoma. So the opportunistic infection depends upon the endemicity of that infection, particularly microbial agent, and the HIV stages of the HIV illness of that infected person. I have already mentioned that the tuberculosis is the commonest, and there are other opportunistic infections. Less common are oral candidiasis, diarrhea, herpes zoster, herpes simplex, cryptococcal meningitis, PJP, CMV retinitis, toxoplasmosis, and bacterial pneumonia. There is gradual decrease in the incidence of these infections. And what is the common presenting symptoms? Fever is the most common presenting symptoms. It is usually associated with cough and weight loss. And there may be respiratory opportunistic infection. And then there is associated dyspnea. There may be lymphadenopathy. Diarrhea is another common complaint. And abdominal pain, asthenia, skin lesions are quite common. TB patients may have, lymphoma patients may also have night sweats, chest pain may be there, and CNS infections are usually associated with altered level of consciousness and seizures. There may be hemoptysis, hematemesis also. দিদি একটা ক্লাসে আছি, পরে কথা বলছি। So it is very important to know that the strategies for there is strategies for diagnosis of opportunistic infection, and the management of opportunistic infection, and the initiation of ART. It is very important. And what is the recommendation during pregnancy? And you have to understand the geography of the distinct opportunistic infection, like leishmaniasis is the stage 4 illness among the HIV infected patient, penicillinosis, and which is more common in the northeastern part of the India. And drug-drug interaction is also very important for treatment of opportunistic infection. This chart shows you the common bacterial, viral, fungal, and the parasitological opportunistic infections. The TB is the most common. Other respiratory viruses in bacterial illnesses are streptococcal pneumonia infection, Haemophilus influenzae, staphylococcal infection, intestinal infection, which are common bacteria, that is Salmonella, Shigella, Escherichia, Clostridium difficile is another one, and the MAC is quite less common in the India. Common viral infections are varicella zoster, HSV, CMV, HPV, NEPV is another common virus, JC virus, HHV8, and Kaposi sarcoma. Common fungal infection, candidiasis is the most common fungus. It may be oral and esophageal candidiasis, pneumocystis girovesi, cryptococcal meningitis, and the Talaromyces is another important, likely, and the histoplasma. And in parasites, Toxoplasma, Cryptosporidia, modified germ positive organism like Cryptosporidia, Isospora, Microspora, and another common organisms are Giardia and Entamoeba histolytica. So these are the systemic involvement. And common diagnostic facilities like the tuberculosis, paucibacillary tuberculosis forms, and that atypical clinical presentation of disseminated tuberculosis and the poor sensitivity of existing screening tests available, especially in PLHIV with very low CD4 count. And it is another important thing is that difficult to get a good clinical specimen in the children from the pulmonary extrapulmonary site. And the facilities for diagnosis of EPTB are not present in all ART center like USG and ophthalmoscopy. Candidiasis, non-availability of the referral facilities like where endoscopy is a common problem, and JC virus, JC pneumonia. So it is diagnostic problem is there because valve fluid test is very difficult to perform among the 8 ART center level. Cryptococcal meningitis, we will discuss the CNS infections later, or chronic diarrhea. Lack of sensitization across all the ART centers lead to lesser diagnosis, and CMV retinitis, ophthalmologist opinion is needed for treatment initiation. And treatment related challenges like cryptococcal meningitis, long duration of treatment and follow-up and maintenance therapy is needed, and non-availability of certain anti drugs to treat the opportunistic infections at the ART center level is another problem to deal with the opportunistic infection. Now, the second part of the discussion for today's discussion is the central nervous system opportunistic infection. So at the beginning, I must say that all of us know that HIV is a neurotropic virus, and so the CNS manifestations by the virus itself is a separate entity, and the opportunistic infections. HIV can affect the any level of the neuroaxis, including brain, meninges, spinal cord, nerve and muscle. And neurologic disease is the first presentation of symptomatic HIV in roughly 10 to 20% of the patient, but the 60% of the patient with the advanced HIV illness will have clinically evident neurologic dysfunction during their illness. So HIV related neurological disease like acute aseptic meningitis, it may be present during the stage of seroconversion or as an immune reconstitution syndrome. Chronic meningitis, hand, that is HIV associated neurocognitive disorder, HIV encephalopathy, vacuolar myelopathy, peripheral neuropathy and myopathy. And why related problem? Cryptococcal meningitis, toxoplasmosis, CMV retinitis, CMV encephalitis, PMLE, and primary CNS lymphoma, tuberculosis, and syphilis. So these are the syndrome, meningitis. What are the clinical features of meningitis? Patient usually presents with headache, fever, nausea, vomiting, altered level of consciousness. Sometimes a patient with the cryptococcal meningitis may not have fever. Patient may have mild headache. So we should always have some clinical suspicion for the diagnosis of this opportunistic infection. Now the lesions like tuberculoma, toxoplasma, PMLE, syphilis, primary CNS lymphoma, neurocysticercosis usually present as a focal cerebral symptoms. So what is the syndromic clinical presentation? They usually present with the headache, focal neurological signs and convulsion. Some why you may present with the encephalitis-like syndrome, like cognitive impairment, behavioral impairment, psychiatric features, altered level of consciousness, and may or may not be associated with convulsion, like herpes simplex, toxoplasma encephalitis, syphilitic and meningoencephalitis, cytomegalovirus encephalitis. Some organisms may produce myelitis, that is sensory disturbances may be there, paraparesis with the sphincter disturbances. CMV is common, syphilis, toxoplasma, tuberculosis are the common organism produces myelitis. Another one present with the neurocognitive decline, gradual loss of memory, behavioral abnormality, motor function deterioration. So it is common among the hand, that is HIV associated neurocognitive disorder. Now, the commonest CNS infection is cryptococcal meningitis. Commonest organism is encapsulated yeast, Cryptococcus neoformans, and a small group of patients may develop infection with Cryptococcus gattii. Usually, patient present with the features of meningitis. Now it is important, that is, patient may develop subacute meningitis or meningoencephalitis. Some degree of encephalitis features are always there with the meningitis component, and some patient may have cryptococcoma skin lesion or CNS cryptococcoma, but usually they have to be differentiated from other OMA-like lesions, and that usually cryptococcal meningitis disease progress. More neurospecific symptoms typically develop, including altered mental status, neck stiffness, and cranial nerve abnormalities. And cryptococcus is usually disseminated when diagnosed in an HIV-infected patient. So 3 type of diagnostic facilities are available. Antigen detection, it can be done in an outdoor basis, and microscopical diagnosis from the CSF and culture. So for these 2, culture and microscopical evidence, you have to do the CSF and the patient needs hospital admission. Another one is antigenic detection. Antigenic detection can be done from the serum and from the CSF. Usually lateral flow assay is the recommended test. Microscopically, gram staining and the India ink preparation can identify the cryptococcus with the encapsulated, which is an encapsulated yeast, and fungal culture, obviously the gold standard mode of diagnosis. People with HIV suspected having cryptococcal meningitis, propped lumbar puncture with the measurement of the CSF pressure, and is very important because usually the CSF pressure is high, and rapid cryptococcal antigen test is needed from the CSF to detect the antigenemia. So if so there are 2 situations: setting where the access to and no contraindication for lumbar puncture, and the setting without access to lumbar puncture, or when lumbar puncture is not possible. Then if there is possibility of serum crack and CSF crack, we always prefer to do a CSF crack, and when it is not possible, do a serum crack. And when the crack assay is not available, then India ink examination followed by fungal culture is needed. Prompt referral for further investigation and treatment as appropriate should always be recommended. So it is very important to ask for the onset of the symptoms suggestive for meningitis. Do not miss the non-specific symptoms. And if the patient is on ART, ask about the duration of ART, because cryptococcal meningitis may present as the iris. And always look for the umbilication in the cryptococcoma, suspected cryptococcoma lesions, and differentiated with the molluscum contagiosum, because molluscums are umbilicated lesions. Cryptococcomas are non-umbilicated lesions. Serum, and always investigate for the serum crack in the patient with CD4 less than 200 cells per cubic millimeter. It is a NACO recommendations. And in patient presenting with the severe headache, and while the cryptococcal meningitis treatment, suspect as much as possible CSF fluid should be removed. It is the therapeutic removal of the CSF fluid, and therefore all the patient with positive serum cryptococcal antigen for the lumbar puncture. And it is important that a negative result India ink does not rule out the cryptococcal meningitis. So screening and prevention. Screening of cryptococcal antigen followed by preemptive antifungal therapy among cryptococcal antigen positive people to prevent the development of invasive cryptococcal disease is recommended under NACO program, national program, and it is recommended to do cryptococcal antigen test less than CD4 200 cells per cubic millimeter. And screening is not recommended in children less than 10 years because the incidence of cryptococcal meningitis is low. LFA is reliable, robust, and easy to perform and should be used to diagnose cryptococcal infection among PLHIV. And it is recommended to use it in any PLHIV with CD4 count below 200 cells per cubic millimeter. So CD4 less than 200 cells per cubic millimeter, serum and CSF cryptococcal antigen test positive, treat as cryptococcal meningitis, serum positive, CSF negative, treat as cryptococcemia. If the patient is asymptomatic, preemptive therapy for the serum cryptococcemia, and if the patient is symptomatic for cryptococcal meningitis, treat as cryptococcal meningitis. And if CSA CRAG is not possible, and if the patient is symptomatic, consider evaluating for tuberculosis. Cryptococcal meningitis and bacterial meningitis may consider preemptive treatment for cryptococcal meningitis and bacterial meningitis based on symptoms and the reports of laboratory investigations. So preemptive treatment for PLHIV with asymptomatic cryptococcal infection, offer preemptive antifungal treatment if asymptomatic PLHIV test positive for cryptococcal infection. Everyone testing positive for serum or plasma CRAG during screening test should be carefully evaluated for everyone testing positive for serum or plasma cryptococcal antigen during screening should be carefully evaluated for signs and symptoms of meningitis to exclude active cryptococcal meningitis before initiating preemptive treatment. The preemptive antifungal treatment is recommended for pregnant women, as well as, however, proper counseling should be provided. 3 phases of cryptococcal meningitis treatment: induction, consolidation, and the maintenance stage. Induction phase, fluconazole for the patients with suspected cryptococcal 800 milligram dose for adults, 12 milligram per kg per day should be given for 2 weeks, followed by consolidation phase for same dose for 8 weeks, and followed by maintenance phase, fluconazole 200 milligram daily for adults, 6 milligram per kg per day for children, until the evidence of immune reconstitution. ART initiation: in case of the patients with suspected cryptococcal meningitis, ART should be deferred for at least 4 to 6 weeks because it increases mortality if initiate earlier. Thus, ART should be initiated between the 4 to 6 weeks after the successful antifungal treatment. Primary prophylaxis is not recommended. Relative infrequency due to relative infrequency of the cryptococcal disease, lack of survival benefit associated with the prophylaxis, possibility of drug interaction, potential antifungal drug resistance, and the cost, obviously. If cryptococcal antigen test is not available, then primary prophylaxis may be given to the HIV positive adult and adolescent who have CD4 less than 100 cells per cubic millimeter, and recommended dose is 100 milligram fluconazole once daily. Criteria for discontinuing fluconazole therapy: all should be present. Persons is adherent to ART, free from the cryptococcal disease, fluconazole given at least 1 year, CD4 count is persistently elevated to more than 200 cells per cubic millimeter for at least 6 months. If for treatment of cryptococcal meningitis, induction phase should be given amphotericin B deoxycholate 1 milligram per kg per day plus flucytosine at least 25 milligram per kg QID for 1 week, and followed by fluconazole 12 milligram for 12 milligram per kg per day for children, adolescent, up to maximum 800 milligram for 1 week. If there is, if it is impossible or contraindicated, amphotericin B is contraindicated, then fluconazole 1200 milligram should be given along with the flucytosine. Otherwise, alternative 2 regimen is 2 weeks amphotericin B and fluconazole if flucytosine is unavailable. Consolidation phase is same, that is 400 to 800 milligram fluconazole for adults, 6 to 12 milligram per kg per day in children up to 12 weeks, followed by fluconazole 200 milligram for till the person is adherent to ART and free from cryptococcal disease, and CD4 is more than 100 cells per cubic millimeter, and at least 1 year of fluconazole therapy with suppressed viral load. Special recommendation for the management of the increased raised intracranial pressure. If the opening pressure is in cryptococcal meningitis, CSF opening pressure usually very high, you should remove the CSF. Sometimes it is needed to remove CSF daily, and sometimes it is recommended to remove at least 20 to 30 milliliters CSF, and until the CSF pressure comes down to the normal. It is very important to reduce the ICT. Liposomal amphotericin B is a preferred choice in spite of amphotericin B conventional dose, but it is not available everywhere, and liposomal is preferable because it has less side effect, slow release, single dose, but it is not available everywhere, so it is recommended to use conventional amphotericin B and liposomal amphotericin B where it is available. So prevention of amphotericin B deoxycholate related toxicities. Whoever you use the amphotericin B, all of you know that it has renal toxicity. So kidney should be flushed with 1 liter of normal saline containing 1 ampule of potassium chloride over 2 hours before amphotericin B infusion, and patient should be supplemented with oral potassium and magnesium daily till the duration of the amphotericin B, and twice a week hemogram along with the urea creatinine level should be assessed because it causes any bone marrow suppression, hyperkalemia, and nephrotoxicity. So monitoring of serum creatinine, sodium potassium level, and full blood count is recommended in the day 037 and day 07. So monitoring of patients receiving amphotericin B and management of amphotericin B related toxicities. Febrile reaction can be managed with prior infusion of the paracetamol along with hydrocortisone. Relapse. So when there is relapse, why there is relapse? There is inadequate induction therapy is one of the cause. Non-adherent to fluconazole consolidation or maintenance phase another. Fluconazole resistance, CNS, cryptococcoma or gelatinous cyst, immunological failure because of the virological failure of ART. So management of non-adherence, patient should be treated as first episode and enhanced adherence counseling should be given. IRIS is very common among the cryptococcal meningitis patient. So for that reason, if the prior diagnosis of cryptococcal meningitis, always search for an ART is recommended after 4 to 6 weeks of meningitis treatment. And if there is unmasking of iris or paradoxical waning of the iris, that should be addressed appropriately. Persistently elevated intracranial pressure and thought to be mediated by occlusion of arachnoid granulations by fungi and the fungal capsule. This does not necessarily imply cryptococcal meningitis treatment failure. Another cause of cryptococcal meningitis should be ruled out. So operational flow, this is I have already discussed, and this is all I have already discussed. This is the flow chart. Second one is toxoplasmosis. So toxoplasmosis is another important parasite infection. It can produce encephalitis, but commonly it produces the focal brain lesion, and it is common when the CD4 is less than 200 cells, commonly less than 50 cells per cubic millimeter. The organism is not transmitted to person to person. Among the AIDS patient, the toxoplasma common presentation is focal encephalitis with a headache, confusion, motor weakness, and fever. Patients may develop with non-focal manifestations, including only non-specific headache, psychiatric symptoms, focal neurological abnormality. CT MRI of the brain will typically show the multiple contrast enhancing lesions in the gray matter. It is important, and it can differentiate it with the PMLE where the lesions is in the white matter. So this is the MRI picture, CT MRI picture, multiple ring enhancing lesions and common in the cerebellar region, but it presents in the gray matter region and the basal ganglia region. So it is very important to do a CT and MRI picture and the picture showing the ring enhancing lesion. And always ask for the symptoms of headache and confusion, ask for the symptoms of convulsion, stupor, and look for the motor weakness, local deficit. On CT or MRI, multiple ring enhancing lesions clinch the diagnosis of the toxoplasma encephalitis. Always perform imaging test. Differential diagnosis, there may be CNS lymphoma, PMLE, or other neurocysticercosis, cryptococcal. This is the recommended regimen. Drug of choice is sulfadiazine pyrimethamine. They are loading dose of 200 milligram of pyrimethamine followed by more than 60 kg, 70 milligram once daily, less than 60 kg, 50 milligram once daily, along with the loading dose of sulfadiazine 1000 milligram QDS followed, if the body weight is more than 60 kg, 1500 milligram QDS, the treatment should be given for at least 6 weeks, followed by the maintenance therapy. But nowadays, we can alternatively treat with pyrimethamine and clindamycin, and most commonly, we are now treating these patients with trimethoprim sulfamethoxazole, trimethoprim 5 milligram, sulfamethoxazole 225 milligram, one tab twice daily. Discontinuation, when we can discontinue the toxoplasma therapy, and the maintenance therapy is pyrimethamine 25 to 50 milligram daily along with sulfadiazine 200 to 400 4000 2 to 4000 milligram per orally. Preferably we are now treating with imidacloprid sulfamethoxazole double strength tablet 1 tab BD or double strength tablet 1 tab once daily, and we can discontinue after persistent elevation of the CD4 count more than 200 cells at least for more than 6 months. Prophylaxis, primary prophylaxis with the Septran DS cotrimoxazole DS double strength tablet can cover both the PCP, toxoplasma and bacterial diseases. So primary preventive therapy is recommended. Now another important disease is cytomegalovirus infection. It is a double-stranded DNA virus of herpes virus family, can cause disseminated or local disease. Invasive disease like retinitis, colitis, esophagitis, neurological disease. Retinitis is the most common manifestation of CMV-related end organ disease. Usually it is seen in CD4 less than 50 cells per cubic millimeter. And it is a life-threatening infection, CMV retinitis. Otherwise, if you don't treat the patient, it can cause blindness. So most common retinitis, CMV retinitis, peripheral retinitis may be asymptomatic or present with floater scotoma or peripheral visual field defect. CNS Lesions may be associated with the decreased visual acuity or the cranial central nervous field defect. Characteristic ophthalmologic appearance is fluffy yellow-white retinal lesions without interretinal hemorrhage. It is very important, with little inflammation of the vitreous. In the absence of ART or specific anti-CMV therapy, retinitis invariably progresses rapidly with 10 to 21 days after presentation. Colitis, esophagitis, and the other forms of CMV infections. And always ask for CMV retinitis if the CD4 is less than 100 cells per cubic millimeter. Assess visual acuity. Immediately refer to the ophthalmology department for specialized care. Look for indirect ophthalmoscopy. Look for fluffy yellow-white retinal lesion with or without interretinal hemorrhage. This is the picture of CMV retinitis. Blood test to detect the CMV antigen. Culture PCR is not recommended for diagnosis and end organ disease because they are poor predictive value, poor positive predictive value. CSF typically demonstrate lymphocytic pleocytosis, low to normal glucose level, and low to elevated protein level. Management, it should be managed with valganciclovir. It is the preferable agent. At least CMV should be treated at least 3 to 6 months, follow up should be done to make sure that the lesions are inactive, and CD4 should be persistently raised above the 100 cells for more than 3 to 6 months. And therapy should be discontinued after consultation with the ophthalmologist, considering the magnitude and the duration of the CD4 count increase, anatomic location of the disease, vision in the contralateral eye, and the feasibility of regular ophthalmologic monitoring. This is the therapy: valganciclovir 900 milligram, 12 hourly, 14 to 21 days, followed by 900 milligram once daily is the preferable regimen. Now the peripheral lesions is similarly treated. Colitis, depending upon the CMV, esophagitis and colitis, duration is 21 to 42 days until the signs of symptoms are resolved. Valganciclovir is the preferable agent now. Some can treat with foscarnet. It is very costly drug, not available everywhere. Dose is 60 milligram per kg IV TDS or the 90 milligram IV BD. And then now neurological disease, same as dose is same as the CMV retinitis, CMV pneumonitis, also the dose is same as CMV retinitis. Meningitis, so different causes of meningitis are there: aseptic meningitis, cryptococcal meningitis, TB meningitis, bacterial meningitis. Aseptic meningitis, these are the causes like HIV itself or some opportunistic viral infection like CMV, JC virus. Course is biphasic with initial non-specific constitutional symptoms followed by a classic features of meningitis, and skin rash-like lesions may be seen in the varicella zoster. Diagnosis is CSF cell count is usually there is lymphocytic pleocytosis with normal or mildly elevated protein, normal glucose level, and negative bacterial antigen. Management usually symptomatic, and sometimes specific antivirals are recommended depending upon the type of virus. Bacterial meningitis, CSF picture usually high cell count with the high protein, decreased glucose, and gram stain smear or may shows the organism cultures, and antibiotic sensitivity may be there. Empiric therapy should be done, and CT or MRI. Na, cholo, shori kharap lagche. CT or MRI is recommended. Third generation cephalosporin along with the vancomycin is recommended. Alternatively, penicillin or ampicillin or chloramphenicol is recommended. Treatment should be continued for 10 to 14 days. TB meningitis, and the ADA should always be sent, and CSA pressure is high, protein is high, sugar is low, there is lymphocytic predominance. ATD along with the steroids are recommended. So these are the different type of CSA picture with the different cell type, protein, sugar level, and the organisms and different type of meningitis. Now PMLE. The PMLE is a viral infection of the CNS caused by the neurotropic human polyoma virus, John Cunningham virus. Immune suppression classically occurring in the setting of HIV. PMLE incidence is 3 to 5% among the AIDS patient, and sometimes occur in patient treated with ART and manifested as IRIS. And it causes demyelinating lesion in the brain, sometimes spinal cord involvement. Though it is rare, it can happen. Optic nerves are usually not involved, and the time course of this evolving demyelination with clinical progression over several weeks often is a clue for diagnosis. Headache and fever are not characteristic. There is progressive deterioration in day-to-day behavioral and cognitive function. And the lesion MRI picture shows that hyperintense T2 weight image and the fluid attenuated inversion recovery sequences and hypointense on T1 weight sequences. No mass effect or displacement of normal structure is usually evident. To confirm the diagnosis, PCR of the CSF sample for detection of the JC virus can be done. This is the asymmetric white matter changes MRI T2 weight picture of PMLE lesions. Management, that is ART, should be started in patients not on HIV treatment as soon as the PMLEs are recognized, and HIV associated PMLE are often complicated by clinically significant IRIS that may require administration of the corticosteroid. Worse prognosis is associated with high viral HIV RNA level at the time of presentation. And CT scan picture of different type of lesions are there. I have already discussed this. And hand is another important. There may be subclinical decline in cognition, and it is suspected. Clinical suspicion is important. The diagnosis is made in PLHIV with cognitive impairment after ruling out of confounding conditions. These are the pictures of a head, that is HIV associated dementia. It is a diagnosis of exclusion. ART is the most effective treatment, and some ARTs which have the much more CNS penetration should be recommended. AZT, D40, ABC, nevirapine, 3TC has much more penetrations to CSF. This is the less common vacuolar myelopathy, and CSF MRI picture will help you to diagnose the vacuolar myelopathy. There is no specific treatment for HIV associated vacuolar myelopathy, and the vacuolation of myelin sheath, accumulation of the foamy macrophages, microglia with relative sparing of actions are the pathological manifestations. And last but not least, the CNS lymphoma. It is important. It is EV virus associated, and so when the CD4 count is less than 100, it is important. Usually, MRI picture shows periventricular irregular lesions that appear solid on enhancement in one or more sites, and there is prominent edema. Lymphoma is suspected when the toxo IgG is negative and there is focal neurological lesions. And these are few words about the HIV associated neuropathy. Distal symmetric polyneuropathy, different type of neuropathy, mononeuropathy, CIDP, and progressive lumbosacral polyradiculopathy may be there. Neurosyphilis, usually present with the meningoencephalitis. Acute syphilitic meningitis occur within the first 2 years of infection. Some cases are diagnosed at the time of secondary rash. It is very important because now the cases of neurosyphilis are increases, and meningovascular syphilis occur few months to 2-3 years, average 7 years. It is very important to do CSF study, CSF VDRL study, and CSF pleocytosis, and it should be treated. Neurosyphilis is always treated with not the benzathine penicillin. It should be treated with crystalline penicillin. It is always treated with crystalline penicillin or procaine penicillin. So it is, these are the few words, and with this I am concluding about the CNS infections, that is opportunistic infections of the whole session of CNS and the introduction of opportunistic infections. Thank you.
Thank you,
Thank
ma'am.
you, Shilpa.
Yeah, thank you, ma'am.
Sorry, Shilpa.
No problem.
Yes, yes.
Thank you so much, ma'am. Any questions from the participants regarding this session?
Okay, thank you,
Ma'am,
Shilpa.
there are no questions. Thank you so much, ma'am. I'll just quickly run the feedback poll, ma'am.
Okay, okay, sure.
The feedback poll is now on your screen. Participants are requested to please attempt the feedback poll, answer all the 4 questions. Kindly note the next session is on Monday and then again on Friday next week. We are running behind one session. So that's the reason we are having 2 sessions at a time in a week. The next session is on Monday. The topic is nutritional care of HIV infected children and counseling for children and adolescents living with HIV. For this session, you can refer to the chapter number 3.6 and 3.7 of the National Guidelines for HIV Care and Treatment. The next session will be on Friday. The session is HIV and OI respiratory system. For that, you can refer to chapter number 4.3 of the National Guidelines for HIV Care and Treatment. Requesting all the participants to please attempt the feedback poll. Any questions from the participants? You can unmute your mic or you can even type in the chat box. Requesting all the participants to please take the feedback poll. Thank you to all the participants for patient listening. Ma'am, can we conclude the session now?